So welcome back. We're here with Dr. David McCoy, specialist pain medicine physician, and in this video tutorial we're going to be looking at the role of radiology in identifying pain. So I'd like to ask you, Dr. McCoy, what role do X-rays, MRIs, CTs and ultrasounds have in identifying pain?
Well, just like doubting Thomas, unless you can see it, it doesn't exist. And so it is in medicine. We have tests for all sorts of diseases. If you come into hospital with chest pain, you probably get an X-ray, a tracing of your heart and some blood tests. Similarly, for a fracture or for diabetes, they'll take blood and look at your eyes and your kidney function. But for persistent pain, it is difficult to describe. It's difficult to define. It's very difficult to manage, and it's also difficult to treat. Now, it would be nice to think that we have a scan or an X-ray to be able to see the pain, but that is not possible. Frequently, we see MRI scans and CT scans where there is considerable changes associated with degenerative changes, and the patient does not have pain in those areas. Similarly, we see normal scans in which the patient reports very significant pain, and it changes the trajectory of where the patient is at and where they're going. It's always nice to think that we identify a particular joint or particular disc or particular area of the body and treat that because it's been identified on scan. X-rays are generally quite good for acute fractures, but for back pain, neck pain, they can be quite misleading. Degenerative changes, that awful word, degenerative changes, are identified very frequently, and they may or may not be associated with pain. Really, the only reasons for an X-ray is for trauma or a suspicion of cancer. MRI scans are high fidelity, very good definition, probably a little bit better than CT scans, but used for a different reason. They can identify degenerative changes, but also slip discs or disc pathology. But it is important to know where the limitations of these modalities lie. And it's not that we would not be interested in the scans, but looking at the scans will tell you what the architecture looks like. It would be like looking at a plate of food and just trying to describe the taste of what you're looking at just by looking at it. It will give you a lot of information, but not the most important piece. Ultrasound scans do not use radiation and can be applied to many parts of the body. They give lots of information and identify lots of pathology. So muscle tears and tendon injuries can be diagnosed, but whether they are the actual cause of the pain or not is open to debate. So it's important to know which scan to use in which patient and at which time. And essentially, my rule is that if you're asking for a scan, you're asking a question. And you must know the answer to the question or know what you're going to do with that answer before you ask the question. So degenerative changes may be important or they may be absolutely irrelevant. A slip disc may be extremely important. One of the other adages that we use is when the scan is bad and the patient is bad, the scan is probably a good investigation. So it's important to understand the limitations of the investigations that are required and are undertaken because they all cost money. They all use radiation except ultrasound, and they all consume time and resources. So it is important to know which one, in which patient, at what time, and what the result is.
So is there any advice that you would give a case manager who is preparing to send somebody to you in terms of, how do they work out what you're going to need to have a look at? Is there any advice that you could give a case manager in helping them to understand whether they are providing you with all the imaging that you may need when somebody comes to see you?
Many patients come to see me and present me with a report of their radiological investigation as a first piece of information. And I often deliberately ignore it until such time as I've had a conversation with the patient. The imaging will hopefully confirm the suspicion that I have made on clinical grounds. Clinical grounds meaning taking the history of the patient, evolution of events that led up to the injury, doing a very important and pointed physical examination, and coming up with a suspicion of what might occur or have occurred, and then doing the radiology to identify exactly the structure involved and confirm my suspicions, but not to make the diagnosis de novo. So the imaging comes after the clinical examination and history taking, not before it.
Okay, thank you for that. That adds a lot of clarity around, the important way in which they're used, but it does come under it comes to help to confirm the diagnosis, not make the diagnosis. Supportful. Yep. Okay, so thank you, Dr. McCoy, and thank you for joining us again. The next topic we're going to look at is this topic around neuromodulation. What is it? How successful has it been? And when should you or should you not consider neuromodulation for an individual experiencing pain? Hope to see you again. Thank you.